hi everyone. We might get started. We still have a few people coming in. But yeah, so today we're here to talk about managing chronic pain. We have a great presenter. So my name is Darcy. I'll be facilitating today, but we have Dr. Roopa Gawarikar here to present managing chronic pain for this Managing Your Health seminar. We also have Caitlin. She's named as Caitlin HCCA, and she'll be monitoring the chat. If anyone has any questions, if you're struggling to get our attention, you can also message Caitlin directly. So she'll be kind of keeping an eye on that as we go along, which is really great. Just before we start, I'll do an acknowledgement of country. So we acknowledge the traditional owners and custodians of the land on which we meet. We respect their continuing culture and the contribution they make to the life of this city and region. We pay our respects to their elders past and present, and we'd also like to acknowledge any other Aboriginal and Torres Strait Islander people who are joining us here today. So just a little bit of housekeeping. As I said, Caitlin will be monitoring the chat. Sometimes it's a little bit hard to see. So yeah, if you're struggling, just reach out in the chat. You can turn off the video if you need. That can kind of help with the quality if your internet's a little bit slow. And of course, please mute yourself if you're not speaking up to ask a question. Yeah, so when you're asking a question, if you want to put up the hand reaction button or just unmute yourself or even ask in the chat, those are all options. And there's no such thing as a silly question. We encourage lots of questions, whatever you're thinking. I'm sure other people are too. We've got a nice number of people today, so there should be a good amount of discussion. We might take some breaks for questions depending on how we're going for time, or we'll stop at the end. But as I said, feel free to just keep popping those questions in the chat as we go along. And yeah, I might hand over to Dr. Roopa. So I've just got a little bit of an introduction here, but I might also hand over to her to introduce herself before we get into the presentation. But Dr. Roopa is a dual qualified specialist pain medicine doctor, radiation oncologist, and interventional pain specialist. She has expertise in minimally invasive procedures, as well as chronic back and neck pain, neuropathic pain, headaches, pelvic pain, and cancer pain. And she believes in comprehensive pain management. So I'll hand over to you now, and feel free to just start right away on the presentation. Thank you very much.
Thank you, Darcy, for your kind introduction. And I'd like to thank yourself, Caitlin and Michelle, and also HCCA for this wonderful opportunity. Also, thank you all for taking time out this evening to have a listen to this presentation. So I would start by saying I have no disclosures here. And I will start by talking a little bit about the prevalence and incidence of chronic pain. So chronic pain is a frequent condition which affects an estimated 20% of people worldwide. 1.6 million Australians aged 45 and over had chronic pain in 2016. GPs are seeing more people with chronic pain, and patient encounters have risen by 67% over 10 years. In 2017-2018, there were nearly 105,000 hospitalizations involving chronic pain. Chronic pain increases with increasing age, and almost 1 in 4 adults aged 85 and over experience chronic pain. So we'll start by defining what is pain, and this definition comes from IASP, which is highest body of pain. The full form is International Association of Study of Pain. So they define pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So usually when one has any injury, it is thought that the injury or the body will heal up by 3 months' time. So that is the rough time frame required for healing after any acute injury leading to acute pain. However, When the pain persists for longer than 3 months, that's when it is defined as being chronic pain. Such pain often becomes the sole or the dominant clinical problem in some patients. As such, it may warrant specific diagnostic evaluation, therapy, and rehabilitation. Chronic pain is multifactorial, and there is a combination of biological, psychological, and social factors which contribute to the pain syndrome. So I will now talk about the multifactorial causes or the multiple causes which lead to a chronic pain picture. So in patients with chronic pain, is very unlikely that there will be only one cause causing the chronic pain. Usually there is a combination of various factors, and those factors can range from biological factors. So say if somebody had an injury, or in some patients it is arthritis or inflammation, so there is always some biological cause. However, then there can also be combination of psychological factors, and the psychological factors can be issues such as mood disorders, such as if patient has got anxiety, depression, PTSD. All of them are going to amplify the pain experience. And why this happens is because the centers in the brain, the pathways which are sensing and processing pain and mood are exactly the same. Also, the chemicals in the brain for pain and mood are exactly the same. That is why when one feels low, depressed, frustrated, the pain level go up. And also when the pain levels go up, one can feel that their mood is feeling much lower or more anxious or more stressed. The other set of factors which also can lead to the chronic pain picture are sociological factors. So sociological factors include factors related to work environment, home environment, stress related to finances, stress related to managing kids, the support network one has. So if a patient has got a lot of social stressors, they in turn are also going to feel that the pain levels are higher, because that also impacts or feeds into the chronic pain picture. So as you can see, that chronic pain is usually due to a combination of various factors. One of the other important factors which is also present in many patients with chronic pain is called central sensitization. So central sensitization is usually seen when one experiences pain for a long time. What happens is that when the brain has been processing the pain signals for a long time, the brain becomes very good or super good at sensing pain. This in turn leads to amplification or heightened pain levels. So what we say is that the brain is a neuroplastic organ, and if it does something, it becomes better and better and better at doing something. So in this case, the neural circuits which are processing pain, over time they become faster, stronger, and this in turn leads to amplification of the pain levels or the pain experience. And this in turn also is one of the factors which is contributing to this ongoing and amplified chronic pain. Now, as I talked, that pain is usually due to a combination of factors. Therefore, the management of pain is also requiring multimodal treatment, because it is happening due to various factors. So the treatment also involves a lot of combination of what we call multimodal management. So the aspects which one looks at when managing chronic pain is firstly pain education. Then we also look at non-pharmacological treatment, pharmacotherapy, procedures, physical rehabilitation, and in some patients, psychological input. So all these treatment modalities usually go hand in hand so as to get the best or the most optimal outcome. Without addressing each component, it is unlikely that pain management targets will be reached. Reasonable goal may be more than or equal to 30% reduction in pain or improvement in function. So I will start by talking about pain education. So education around chronic pain is useful so that one can get an understanding of the pathophysiology or the cause of the various factors which are causing pain, such as the biopsychosocial model or the biopsychosocial causes which I talked about. Then also understanding the concept of central sensitization, and also understanding the relationship between mood and pain. So you can have an understanding that, okay, today I'm feeling a bit stressed, I'm feeling low, frustrated, and my pain levels feel high, or my pain levels are high and my mood is affected. So you get a bit of a background idea of what's going on here. So as I said, central sensitization is one of the common factors which is seen in chronic pain. Also, understanding, as I said, the relation between mood and pain, and also the relationship between sleep and pain. So in patients with chronic pain, many times the sleep is poor, and this in turn leads to heightened pain levels. So again, pain and sleep are both feeding into each other. So patients with high level of pain will find it difficult to sleep, and in turn, when their sleep is poor, their stamina to deal with pain becomes less, and in turn the pain gets higher. So you can see how they have a bidirectional, or they're both kind of affecting each other. Also, with pain education, one can understand the concept of self-management and the various techniques one can adopt for self-management, which I will be covering later in my talk. Some of the common resources which you can look up are books such as Manage Your Pain by Professor Michael Nicholas, and also Explain Pain. There are also online programs. One of the common ones is Reboot or This Way Up, which is by St. Vincent's Hospital. And this is a multidisciplinary approach to pain management based on cognitive behavior therapy model. Websites such as the ACI Health website also provides information on understanding pain and self-management resources. Now, some of the simple non-pharmacological treatment which may have some use are simple things like using a heat pack, a cold pack, or a TENS machine. So TENS machine is something which you may be able to borrow from a pharmacy or get it from a pharmacy. It basically works on what we call the gate principle. So TENS machine basically sends soft touch to the area where there is pain. And the hypothesis is that when touch signals are going up your spinal cord, the gate is closed for pain signals, because only one type of signals can go up the spinal cord. So this in turn leads to some level of masking of pain. So it's not going to be a magical treatment for pain, but it may give you like a 20-30% masking of pain. So the combination of this is usually less harmful. It has no side effects, and it can be utilized on a day-to-day basis. Coming to pharmacological treatment. Now, we usually start in a stepwise ladder approach, and we start with simple analgesics like paracetamol or anti-inflammatories. These should only be taken on an as-needed basis, ideally. In some patients, we call them adjuvant medications. So in some patients, they may be useful, and these medications are basically meant to reduce the central sensitization. So when the brain becomes hyper-responsive to pain, these medications can be utilized as a way to dampen that pain experience. Also, these medications are used for nerve pain. So in patients with neuropathic pain, these medications can be utilized. The other type is a compounded cream. So compounded creams are a less problematic, or they have less side effects compared to tablets, and they can also be utilized to be used on various areas where one has pain. Coming to opioids. So the Faculty of Pain Medicine recognizes the lack of definitive evidence supporting long-term effectiveness of opioid analgesics in patients or people experiencing chronic non-cancer pain, and the substantial evidence for potential harm. Guidelines recommend that non-pharmacological and non-opioid medicine therapy should be optimized before considering opioids, and they are not recommended for long-term. So I had one of the questions asked by Michelle was to talk about regulation, or has there been any change in regulation with opioid use? So I just wanted to bring this to attention. So Australia's annual overdose report in 2020 identified that 900 deaths were attributed to unintentional overdose of opioids in 2018, representing 9% increase since 2014. Opioid-induced respiratory depression is a fatal complication. So why is there so much legislation around opioids? This is because these opioids can lead to fatal complications through a process called respiratory depression. So what is respiratory depression? So opioid medication basically they have the propensity to depress the respiratory center in the brain. They can also weaken the muscles of the upper airway and weaken the muscles of breathing, and also sedate the patient to such extent that they cannot physically take a breath. And this in turn leads to what we call respiratory depression. You physically are not capable of taking a breath, and this leads to death. Not every patient can be revived, and not every patient reaches the hospital in time. And because this is a fatal complication, there is so much legislation around opioid usage. So Canberra script is ACT's real-time prescription monitoring system. It was launched last year. It is intended to reduce harm and preventable deaths in the community by supporting safe and effective use of these monitored medication. Another thing is an opioid contract, which is a document which can be utilized, and it is basically a document between the patient, the pain specialist, and the GP, so that everybody is on the same page as to what type of opioid and what dose of opioid the patient is on, so that there is no confusion. Also, it lays out some other principles that the patient should have a single prescriber, a single pharmacy, and there should be a guideline as to stopping or seizing the opioids at some time point. Also, the opioids are meant to help the patient so that they can improve their function, their sleep, and the quality of life. Now, ketamine infusion is another treatment option, and we usually use it in patients when they have debilitating pain, which is not responding to standard analgesics. Ketamine is a powerful analgesic, and it aims to break the cycle of pain and dampen pain. When it breaks the cycle of pain, it can also lead to reduction or dampening in that central sensitization. So ketamine infusion is aimed to reset the overprotective brain circuits, which are amplifying the pain level even further. It can also reset opioid tolerance. It also is known to help with depression and anxiety. As it says, infusion, it is given as a drip under supervised environment. So ketamine can be used for various pain conditions such as chronic headaches, in patients when they have got nerve pain like a burning or tingling, numbness in the toes and fingers. Also in patients when they have amputation and they have phantom pain. It can also be used in a specific condition called complex regional pain syndrome. It is also effective in patients who have opioid resistant pain, and they can help wean and reduce the dose of opioids and overall reduction in the opioid requirement. Also, we can use it for patients with chronic pelvic pain, fibromyalgia, and in patients with various intractable pain conditions, which is refractory to opioids. Now, coming to the next aspect of pain management, which is the procedural aspect. So procedures form one of the part of multidisciplinary pain management. So they are not the sole treatment, medications are not the sole treatment. So all of these treatments are working hand in hand in order to dampen the pain, so as to reduce the interference of that pain on your day-to-day function, your mood, and your sleep. So if the procedures are able to dampen pain, one can reduce the reliance on medications, wean the medications, and so in turn reduce side effects such as fogginess and weight gain, which can happen with these medications. Now, I will start by talking about the various common type of procedures which can be utilized. I'll start with pulsed radiofrequency. So this is a procedure which is used to dampen pain. It involves sending electrical signals using a needle or an electrode to a nerve to slow down or dampen pain transmission. Now, pain, what is pain? Pain is basically electrical signals which are going along a nerve, right? So what happens is, by using pulse radio frequency, one can slow down the transmission of electrical signals, which is leading to high level of pain. And this in turn can dampen the pain. Pulse radio frequency is not a destructive treatment. It does not heat the nerve, and it does not create any damage to the nerve, other than slowing down the transmission of pain signals. The pain reduction usually lasts for 3 to 6 months, and if need be, the procedure can be repeated. Now, pulse radio frequency, some of the common indications are in patients when they have got headaches, such as occipital headache present at the back of the head. In those patients, this is what the needle looks like, as you can see in the picture. It involves putting the needle in specific areas at the back of the head, and this sends signals to the nerve to slow down the pain transmission, and it can lead to statistically significant reduction in pain, improvement in the quality of life, and reduction in the usage of adjuvant pain medications. Other common indications include knee pain, where it targets the nerves which are carrying pain from the knee joint. The nerves are called genicular nerves, and in the picture where the position where the needles are placed are where these nerves run. So the needles are placed in vicinity of these nerves, and signals are sent so as to slow down or dampen the pain transmission. The procedure is usually done under extra guidance, and they are day procedures. So similarly, the same concept can be used in a patient where they have got pain coming from the hip joint. So in this case, the two nerves which are carrying pain from the joint are targeted. Again, now coming to the shoulder joint, the same procedure can be used where we target the nerve carrying the pain from the joint, and there is one more nerve where we target it, and that carries pain from the rotator cuff, which supports the shoulder joint. Another type of procedure which can be used comes under the umbrella of what we call regenerative medicine. So platelet-rich plasma is a form of regenerative medicine as it promotes the healing of any musculoskeletal condition. Now, what is this platelet-rich plasma? So platelet-rich plasma is basically, it has a high concentration of cells called platelets, which carry growth factors or healing factors. And wherever we inject this, it means to heal that area. So say if you have got a ligament tear or a tendon damage or inflammation in any joint, injecting this plasma with growth factors can heal up that area, can reduce the inflammation, and in turn reduce the pain. How it is done is by taking around, usually we take around 10 ml of blood from the patient. That is then rotated at a very high speed in a centrifuge machine. As you can see in this picture, there is plasma, which is the yellow fluid at the top, and it is separated by a gel, and at the bottom there is red blood cells. So it separates the plasma from the red blood cells, and this plasma has got the growth factors, the healing factors, which is then injected in various areas where they need healing. So this is also not a destructive treatment, but it is a healing treatment. Now, where can it be used? So it can be used in arthritis of the knees, shoulder, hip, spine, ankle, plantar fasciitis, tennis elbow. Trochanteric bursitis is another indication, and it is quite commonly seen where one can have pain on the upper outer thigh or the upper outer aspect of the hip joint. Also, we can use it in ligament sprains, and rotator cuff is the cuff or muscles which support the shoulder. Sometimes there can be a lot of wear and tear to them, and it can also be injected to help with the healing of these muscles. Now, if say the pulse radio frequency, which I talked about, or the PRP, which I talked about, they are both not destructive treatments. They are treatments which one would use first, and only if that is not enough, then we use the radio frequency ablation. However, in back pain, radio frequency ablation, which I'm going to talk about now, is the very more standard treatment, as it is backed by a lot of evidence for back pain and also neck pain. Now, each nerve has a glad wrap around it, which is called a myelin sheath. And this glad wrap is important for any pain signals to go forward. So in radio frequency ablation, one sends heat signals to this glad wrap so that this glad wrap gets interrupted. So instead of being a continuous sheet around the nerve, it gets broken up due to the heat signals. And when it's broken, the transmission of pain signals is interrupted. And this in turn leads to dampening of pain. So the pain dampening can last anywhere from 6 to 18 months because this glad wrap then regenerates. However, usually when the pain dampens, that is the time to engage more in physical rehabilitation and improve your own stamina and own core strength to improve or dampen pain. And also it is said that once we are able to break the cycle of pain, usually when the pain comes back, it can be at a lower level than where it was to start with. So as I said, radiofrequency ablation is backed by a lot of evidence for especially pain arising from the back, which is usually common. One of the common conditions can be due to arthritis or inflammation in the joints called facet joints, which are the tiny joints in the back. It can also be used to dampen pain arising from the very lower back, where the joints are called sacroiliac joints. So that is quite a long joint between the hip bone and the sacrum. And radiofrequency ablation can be used in patients where the pain is arising from this joint. We can also use this for patients with knee and shoulder pain if pulse radiofrequency has not given enough relief. Now, the next topic is, again, for procedures is under umbrella term. It's called neuromodulation. So I don't want you to get too much bogged down by the terms here, but I'll try to explain that in simple terms. So neuromodulation, because our nerves can be peripheral. So we can have nerves in extremities like a hand, our feet, and then there is also the central nervous system, which is the brain and the spinal cord. So neuromodulation can be applied to any nerve in the extremity like the hand or the feet, or it can be applied centrally to the spinal cord. Now, all these procedures are usually used in a stepwise fashion. So one would start with the simplest treatment, and if that is not enough, then move up the ladder. So the neuromodulation, which is peripheral nerve stimulation, that involves placing a small needle, or it's called the electrode, in vicinity of a peripheral nerve, like as I said, a nerve which is in the hand or the foot or say the groin, or so somewhere not in the spinal cord but more on the outside. This electrode aims to activate the nerve fibers that carry normal sensation such as touch, and this in turn slows down the transmission of pain sensation and reduces pain. So what happens is each nerve has got fibers which are sensing normal sensation like touch, and it has got fibers which sense pain sensation. So when you have had pain for a very long time, the fibers which are sensing pain are very active. They are like the more dominant part of the nerve. So using this technology, what we do is we try to activate or stimulate the fibers which are sensing normal sensation like a touch sensation, so that those normal fibers become more active and the fibers which are sensing pain become more dormant. So we are trying to reverse the equation. So rather than pain being at the top and normal sensation at the bottom, we try to reverse it so that normal sensation is the more dominant and pain sensations are more at the bottom, are more dormant, or more like less active in the nerve. So this can be used for dampening any nerve pain, headache, surgical site pain, complex regional pain syndrome, and also in patients when they have got burning nerve pain in the feet or the fingers. So some of the common areas which it can be used for is the occipital nerve stimulation for headaches. It can also be used to stimulate the nerves which are carrying pain from various joints like the shoulder, knee, hips. So this is peripheral nerve stimulation. Now coming to spinal cord stimulation, this involves sending signals to the spinal cord to block them from traveling up the brain. Now spinal cord stimulation is usually done as more like when the patient has failed the other treatment modalities, and also after a very thorough multidisciplinary assessment. Some of the indications are phantom limb pain. The term failed back surgery is for patients when they have had surgery for various conditions and they have ongoing back and leg pain. Also, it can be used for complex regional pain syndrome and patients with painful nerve pain in the extremities. So in summary, these procedures are aimed to dampen the pain by slowing down the pain transmission, or by healing up the area, or by using both techniques together as well. The aim of these procedures is to dampen pain and reduce the distress and interference of pain on daily life. Each patient is very different, and so the procedure which can be utilized or which can be indicated for each patient is going to be very different. Now coming to the concept of physical activity and exercise. So this is equally important. As much as we want to dampen the pain, physical activity and exercise is equally important. and has to go hand in hand with all other treatment modalities. So physical activity and exercise can range from low impact exercises such as Tai Chi, hydrotherapy, whole body stretching, or it can involve muscular strengthening and endurance, or aerobic exercises, or flexibility and stretching exercises. So the aim of these exercises is to improve cardiovascular fitness, improve strength and muscular endurance, reduction in pain by releasing endorphins. Also, exercise is known to reduce anxiety, depression. Exercise also strengthens, it's called the descending inhibitory pathways, which dampen pain. So what happens is all of us have got these descending inhibitory pathways, which naturally dampen pain. So for example, say if you jump into a pool of cold water, initially you will be very uncomfortable and it really bothers you, but after some time, you start feeling less uncomfortable. What happens is not that the pool has suddenly heated up, it's because your descending inhibitory pathways have activated and dampen that pain, so that and dampen that discomfort sensation, so that now you start feeling more comfortable. However, when you have chronic pain, these pathways, they become malfunctional and they don't work as properly. So by exercise, you can bring them back and can strengthen these inhibitory pathways. Now, another important concept is pacing. So pacing is a very important and a very simple thing to understand, but it is not easy to implement in day-to-day life because we all like to get things done very fast, right? So now what is pacing? So pacing implies that one should break the activity into small bite-sized pieces rather than being trying to eat the whole pizza or trying to do the whole thing in one go and then end up in a flare up and being in bed for the next 2 days. It is better to pace the activity. So do everything in small bite-sized pieces so you can get the task done. You don't have a flare up at the end, and next day you can keep doing what you're doing. So rather than having a boom and bust cycle, it is better that one paces their activities. Now, pacing can be applied to any activity such as standing, walking, sitting. With pacing, one can complete the task with less flare-ups. So how do you pace? So say, for instance, if you are wanting to pace your standing activity. So I would recommend you take 3 to 4 baseline readings over 3 to 4 days for the standing. So say today you're able to stand for 10 minutes before the pain starts. Tomorrow is 15 minutes. The third day it's 20 minutes. Then you take an average of that and reduce it by 20%. So this is the limit where you should stop. So say the average of all of this say comes to say 12 minutes. So that is where every 12 minutes you stop from standing, you sit down, take a break, stretch, take a little bit of a breathing space, and then go back, stand, do what you need to do. So say if you're chopping vegetable, don't stand there and chop for an hour and then be in a lot of pain. Rather try to have a little bit of change in posture. Slowly you can increase the limit as tolerated. There is no rush towards it, but you can slowly increase it. Always start low and go slow. You should pace on good days and also not on so good days. So just because it's a good day, you should not keep doing activity and then go into a flare up. Rather, still continue to pace your activities. Now, psychological input. Now, because as I said, mood and pain are interlinked, that is why managing mood is equally important when we are managing pain for the best outcome. 35 to 45% of patients with chronic pain experience depression. Anxiety, depression, and other mood disorders occur at the same time as chronic pain from conditions like fibromyalgia, back pain, and migraine. Chronic pain is also common in patients with PTSD. So that is why managing mood is as important as managing pain, and both should be managed in parallel to achieve the best outcome. Now, the type of psychological interventions can range from desensitization techniques. So desensitization techniques such as relaxation techniques, which can include deep breathing, meditation, mindfulness, is to desensitize the central sensitization. So to desensitize the hyperactive or hyper-responsive nervous system. So these are techniques which one can implement almost on a daily basis in order to achieve desensitization. Also, cognitive behavior therapy can be useful. So unhelpful thoughts such as feeling thoughts such as this is the worst day, I can never get this done, my back is broken. So thoughts, such unhelpful thoughts and phrases are going to impact on how you feel. And also what you say is what your brain also tends to believe. And if we say that my back is broken, your brain is going to believe your back is broken. Also, you tend to feel quite low thinking about that, that is the situation your back is in. And when you feel low, your pain levels automatically will feel higher because, as I said, the pain and mood are highly interlinked. Your motivation goes down, you tend to do less, and everything starts to go in a downward spiral. Instead, trying to see, can I convert this unhelpful thought into a helpful thought, such as I can never do this, rather than thinking like I can never do this. Try to say, it's difficult, it's hard to do, but I have done this in the past. I may be slow at doing it, but I think I can get it done. So trying to convert an unhelpful thought or unhelpful phrase to a helpful phrase can help in how you perceive and how you manage your pain. In some patients with mental health conditions such as depression, anxiety, PTSD, it is very important that that is thoroughly evaluated and managed appropriately by a mental health team, which can include a psychiatrist and psychologist. Now, also talking about sleep. So sleep is very important to have good energy levels during the day. So you have got the stamina to do what you have to do and also have the stamina to deal with pain. When your sleep is poor, your pain is going to increase. In turn, poorly controlled pain is also going to make your sleep worse. So both are feeding and both are affecting each other. So some simple strategies to improve sleep. I'm sure most of you already know this, but just wanted to bring it up again. So trying to avoid any stimulant like alcohol or caffeine close to bedtime. Also remove electronic devices from bedroom, avoid daytime naps. So try to see that you are trying to have the sleep only during the night time and not during the daytime. And also having a regular sleep routine. So these are simple things which can be utilized. In some cases, they do need medications and they do need a bit more intervention to help with their sleep. But managing sleep is also a very important part of overall pain management. So in summary, the cause of pain is multifactorial. And so in turn, the management of pain is also involves a combination of various strategies which have to be used together, not one after another, but almost they have to go hand in hand or in parallel. Each person is very different. And so the management of each patient also has to be highly individualized. The aim of all these treatments is to dampen the pain and in turn improve function, mood, and sleep. It is important not to lose hope and seek for assistance. Also, remember, pain management is a slow journey and you are in charge and you are in control, and we are here to help you and assist you. Thank you very much for your time today.
Thank you, Dr. Roopa. Do we have any questions? They can be in the chat or unmute yourself if you like. I know you've answered a lot of the questions that came through Eventbrite, but I'm just trying to find if we've got some extra ones. There was a good question about what to do when maybe someone like your pain specialist or your GP isn't really taking that chronic pain seriously. Do you have kind of any advice or strategies for those types of people?
See, it's difficult because in the first place, pain should be acknowledged. So that is like the first principle, that if a patient has pain, that has to be acknowledged, that there is real pain and that they are distressed or they are suffering with the pain. So that is the first principle which has to be followed. So for someone not to acknowledge pain is not the right thing to do. So ideally, but if the patient is facing such situation, then in the first place, that is not an ideal scenario. So I think it's difficult because, as I said, that in the first place should not happen.
Yeah, definitely. We do have another question in the chat. So if pulsed and ablation hasn't helped with back pain, what would be the next best suggestion?
Okay, so I think one should then go back and reevaluate. Is the cause correct? Has something changed? So going back to step one and seeing, are we treating the right area? Is it that the treatment has failed, or is it that something new has happened? So going back to step one, reevaluating, and then seeing, is there a new problem which needs a different type of treatment? Usually radiofrequency ablation is the standard treatment, and it is a strong treatment because we are heating up the sheet of the nerves. So it is possible that that patient can either have a new problem, or it's possible that they can have a multitude of problems. So there can be more problem than just facet joint arthritis, which is contributing to pain, and those aspects have not been dealt with. Such as disc, for instance, it can be a disc problem, or it can be issues with the ligaments. So they have to be treated separately. For them, you cannot just use radiofrequency ablation.
Thank you. Feel free to post more questions if you have them. I'm just looking through. Another one we have is do you have any tips about kind of dealing with the sort of unpredictable nature of chronic pain? And I know you sort of talked about some of those kind of psychological things or alternative treatments, but yeah, just that kind of issue of not really knowing when the flare-ups are going to happen.
So not knowing when the flare-ups are going to happen is usually indicative of nerve pain, usually. Because when you have got any type of mechanical pain leading to a joint, or say like a knee joint or a back, usually those mechanical pains are more predictable, because it usually would happen when you have overworked those joints. So, you know that you have overdone activity, you have a flare up, and then you deal with it. Whereas if it's unpredictable, it's usually more due to nerve, because nerve pain can just spontaneously flare up, or it could be that you have high level of sensitization, and that is why issues such as cold weather or change in humidity or pressure can suddenly flare up your pain. So those unpredictable flare-ups are obviously one can feel a bit more shaken, like you don't know when to predict a migraine or like a flare-up. In those cases, the first thing would be to make sure that you have an idea, is this flare-up like my usual flare-up, even though it's unpredictable? Is the nature of this similar to what it has been in the past? Like, it's not a new problem, it is the same problem, but this is like the usual flare-up I have. If it is, however, a different type of pain, then again, we have to make sure that you don't have a new problem. But if it is the same type of pain, then the first thing would be definitely to make sure that you don't panic, keeping calm, knowing that, okay, I have had this flare up before, it did resolve, I did overcome it, and just knowing that, yep, it's possible to get through it. The second thing would be, we usually tend to have a flare-up management plan. So the flare-up management plan is starting with simple things like, as I said, using a heat pack, cold pack, start with simple analgesics. And if that is not enough, then we try to escalate the treatment. So that is something you will need to work out with your GP or your pain specialist. So having that stepwise approach to, okay, I will do this, if not, then I do this, if not, then I do this. So having that stepwise approach is also good, because then you know, what am I going to do when I have a flare-up? And then also important that when you have a flare-up, obviously, if it's very bad, that's different. But if it's moderate, then, and if it's related to a part like a back or knee, important that you also not get completely immobilized. So having some even gentle level of activity, so you don't completely get, stiffened up, is also a good thing. And at those times, the main thing would be to make sure you don't panic and just follow the flare-up plan.
That's a great answer. Thank you. We do have a few more questions in the chat. So the first one that's come through is, how do people get access to the treatments that you've mentioned today?
So see, all these treatments are very individualized. So it's very hard to put them all in one box, okay? And also, as I said, we usually start with simple things. So as simple as, if that is enough, we don't need to go up the next step. So these treatments are done by, they're not done by radiologists, are done by pain specialists. So ideally, you should be seeing any pain specialist or go to a pain management clinic in order to access these treatments.
Thank you. The next question we have is, how effective is implanted neurostimulation of the spine when treating cancer pain?
Yeah, so see, cancer pain is a more aggressive type of pain because obviously there is usually if there is erosion of the bone or there is some damage to any of the spinal nerves, okay? So in those cases, it very much depends on the pathophysiology, on the type of problem which is present in order to know whether the spinal cord stimulator would be useful or not. There are contraindications for spinal cord stimulators which have to be very strongly followed because it is a very high-end procedure, so it has to be taken very seriously. And in cancer patient, there can be a variety of different causes leading to spinal pain. So it very much comes down to what is causing that pain, and then one can decide, is this going to be suitable or not?
Thank you. The next question we have is, if a patient has been treated with opioids long-term and meets the criteria for dependence, can the other discussed treatments be used, or does the patient need to withdraw from the opioid first?
See, this is a difficult scenario because depends upon how much opioids the patient is on. Usually, if it is like not a high dose opioids, then one would consider implementing these other treatments like say ketamine infusion or adjuvant medications or procedures to dampen the pain such that the patient can then look at weaning down the opioids. Whereas if they're on very high doses, then ideally we look at ketamine infusion as the first treatment to seek how much can we reduce, and then look at procedures to see can we reduce further. So again, it just comes down to how much the opioids are. But if you're on opioids, then we just don't say go cold turkey or just stop ASAP. We usually will try to look at options to dampen your pain so that then you can attempt to contain the opioids.
Thank you. The next question is, when are cortisone injections appropriate to ease trapped nerve pain?
So cortisone injections are usually appropriate. So, and they are like the first line treatment. However, when I say first line means as pain specialist, they are more taken as a diagnostic tool. So if you have injected a local anesthetic or cortisone in any nerve or joint and the pain improves, it tells us that the target is correct. And then we start using all these treatments. So that is look more like a diagnostic tool to see, are we at the right target? However, in some patients, we can just use that as a way to dampen pain for some time. So if say you have got a nerve which has been compressed by a disc in the back causing pain going down the legs, then yes, absolutely cortisone injection can be utilized to see if that swelling of the nerve can be reduced and in turn pain can be dampened.
Okay, and the next questions are, what are the options in terms of maybe supplements or medicine to help with sleep? So got a question about sleep here. What are the options that will have minimal interaction with other medicines or things like weight gain?
Sorry, two questions, is it? Two different questions?
No, sorry, all the one question. But yeah, basically, what are the options to improve sleep when it comes to kind of medicine or supplements?
Right. So see, with medicines, we try not to add benzodiazepines, which are very addictive. They are very addictive, and they have got a lot of other problems. So we try to stay away from them. One can use melatonin. So melatonin is a natural hormone, okay, which can improve the circadian rhythm. So circadian rhythm is how our brain knows that it's light and it's time to wake up, and now it's dark, it's time to sleep. So melatonin helps to improve that circadian rhythm, and it is a natural medication, and that is something which we can start with and can also increase the dose, but it has to be taken almost every day to start seeing that pattern or circadian rhythm getting better. Other than that, some of the adjuvant medications which I was talking about for nerve pain and sensitizations, some of them can cause fogginess. So we do use those medications, especially at night, in order to help not just with pain, but also to help with sleep.
Yeah, that's good advice. Thank you. I will just quickly say as well, I think our first Managing Your Health seminar was with Grant Wilson from the Sleep Clinic. So he went in a little bit more detail
Okay, sure.
about not medication specifically, but kind of more talking through the circadian rhythm and kind of what happens to it over time.
Yeah.
So I'll find a link to that recording and post it in the chat if that's useful for anyone.
Yes, that's a good idea.
But yeah, we've just got some people in the chat saying that that was a really good question. It's also things that they struggle with as well.
Yeah, sleep is a big problem. I totally
Yeah.
agree. And firstly, starting with the sleep hygiene. So starting with some of the basic things, which I talked about, that will help. So making also trying to see that if you can avoid daytime naps, because many patients with pain, when they're taking medication, they can feel quite foggy and they tend to have daytime naps, and that in turn affects their sleep at night as well. And then there can be other factors such as pain is one of the common factors. But then, if we tend to overthink at night, that in turn can also impact on the sleep. And in some patients, it's just they have got insomnia. So for various other reasons, sleep apnea is also a quite common reason affecting sleep. So have to make sure that one does not have sleep apnea. So there is usually multiple causes which can affect sleep. And try first starting with sleep hygiene routine. And if that's not enough, then going for melatonin. If that's not enough, then we look. So everything again comes into more like a stepwise approach.
Yeah. We also have another question about medical cannabis. So how useful is that for pain and maybe sleep as well?
So see, medicinal cannabis, the Faculty of Pain Medicine has stated that it should only be used as in setting of clinical trials or as a last resort. So if the standard treatment options have failed. Now, medicinal cannabis comes in two forms. One is CBD only, and one is CBD and THC. So when you have CBD and THC, the THC is the component which causes euphoria and causes more drowsiness. So we try first only to see if CBD alone would be enough. And some of the common reasons why cannabis can be utilized are nerve pain, also in patients where, yes, so sleep is a problem. So those are the common reasons. And CBD as such is a less problematic medication compared to the combination. However, if the CBD is not sufficient, so patient don't feel that they are getting much relief and they want to try the combination, then the combination can be tried. The only thing is in ACT, you cannot legally drive if you are taking a THC product. So that is something you need to be aware of. The cannabis can help with your sleep, and some patients do take it just at night to help with the pain and sleep at night. So it can be utilized. However, as I said, it is not something which we would say start as a first up treatment. So it is more that the standard options have failed.
Yeah, thank you. I know it's one of those tricky things to find out information about. Both HCCA and Arthritis ACT often get asked by their members about use for pain and how to access.
Yes,
Yeah.
I think in palliative care, it is more widely available just because it can also help the cancer patients with their anxiety, appetite, sleep, and that they use more of the THC. Yes.
Yeah. I think that was sort of it for the pre-prepared questions and also in the chat. Did anyone else have any additional questions? Otherwise, we might finish a little bit early, or Dr. Roopa, if there's kind of something that these questions have made you think of that you want to add. But yeah, I think there's been a lot of information so far. I might get Caitlin to pop our evaluation link in the chat, just so you can let us know what you thought of today's presentation. Yeah. I don't think we have any extra questions, so we might finish up. But thank you very much for the presentation today. I definitely learnt a lot of things, and I hope everyone did as well in the chat. We're getting some thank yous in the chat for a very helpful presentation.
Oh, that's good to know. It's my pleasure. So I always feel I love it's my passion to help patients with chronic pain, and it's very gratifying if any person can get relief. And I did feel that I don't want to overwhelm people with a lot of information. So that is why I think I would leave it there. But it's been a pleasure, and thank